Ocular hypertension. In the general population, the mean IOP is 16 mm of mercury. Two standard deviation on either side of this provides a normal IOP range for individuals over the age of 40 years of 11 to 21 mm of mercury. The distribution is Gaussian with the curve skewed to the right. The upper range of normal in individual over 70 years is 23 mm of mercury. It is estimated that 4 to 7% of the population over the age of 40 have an IOP of more than 21 mm of mercury with open filtration angle and without detectable glaucomatous damage. These individuals are referred to as having ocular hypertension. Approximately 1 in 10 will develop glaucoma over a 10-year period, and the majority will not develop glaucoma in their lifetime. So in ocular hypertension, the people have more than 21 intraocular pressure with open filtration angle and without detectable glaucomatous damage, and these are 4 to 7% of population over the age of 40. Risk factors for developing glaucoma. There was a study done on ocular hypertension, and the study was Ocular Hypertension Treatment Study, OHTS. It was a multi-center longitudinal trial. In addition to looking at the effect of treatment of individuals with ocular hypertension, the IOP in one eye between 24 mm of mercury and 32 mm of mercury. So in this study, the IOP was between 24 and 32. So in this study, invaluable information was gained about the effect of range of putative risks for conversion from OHT to glaucoma. Now the percentage of OHT patients likely to develop glaucoma at 6 years, taking key factors into account, is set out in these tables. There were certain limitations in the study. The study goal was in IOP reduction of 20%, which may not be sufficient in some individuals. And second, the compliance with medication was not measured, and there is a possibility that early glaucomatous damage was already present in some patients. Now the conclusions based on factors that were significant on multivariate analysis. The first one is intraocular pressure. So the risk of developing glaucoma increases with increased intraocular pressure. As you can see here the intraocular pressure is more than 25, so there is 36% risk, and below 25 there is 12% risk. So it shows that the intraocular pressure, the risk of glaucoma increase with increase in intraocular pressure. The second is age. Old age is associated with greater risk. The third one is central corneal thickness. The risk is greater in eyes with ocular hypertension and central corneal thickness less than 555 micrometer. As you can see here, the less than 555 micrometer, there is 22% risk. So it is more than the other values. And lower in eyes with high CCT, as you can see here, more than 588 micrometer, there is only 8% risk. So why there is increased risk? This may be due to under and overestimation of IOP. although it is more likely that associated structural factors, perhaps at the lamina cribrosa, might be involved. The CCT can be determined using optical imaging, for example orb scan, or ultrasonography, for example Pachymet. The next risk factor is cup to disc ratio. Here you can see the cup to disc ratio. The greater the CD ratio, here you can see more than 0.5. The higher the risk, 22% risk. This may be because an optic nerve head with a large cup is structurally more vulnerable, or it may be that early damage is already present. Pattern standard deviation, the higher the pattern standard deviation value, the greater the risk. This possibly signifies early glaucomatous field change. Conclusions based on factors that were significant on univariate analysis only. So these were overridden when the factors discussed above were considered. So these were the African American race associated with higher glaucoma. Males are more likely to convert to glaucoma. Heart disease is a significant risk factor. Factors not found to be significant. Myopia, although it is suspected that myopic discs are more susceptible to glaucomatous damage at a lower IOP than emetropic disc. Diabetes, not found to be significant. Family history of glaucoma. It is curious as patients with glaucoma often have a family history of the disease, but in this study it was insignificant. So, conclusion of OHTS study. So the conclusions: the early treatment reduces the cumulative incidence of glaucoma. The effect is greater in high risk individuals like high CD ratio, CCT less than 555 micrometer, and mean IOP more than 25.75. Early treatment of low risk individuals is not needed. And their conclusion was that individualized assessment of risk is useful and help to guide management. So in ocular hypertension, validated prediction models using an individual ocular parameters allow the risk of developing glaucoma to be determined. Genetics of ocular hypertension. A single nucleotide polymorphism in TMC01 appears to be significantly associated with conversion to glaucoma in white people with ocular hypertension. There is threefold risk in individuals with two risk alleles compared with those with no risk allele. Clinical evaluation. History and examination should be carried out as for glaucoma, which we will discuss in the next lecture. Consideration should be given to whether any systemic medication is being taken that might be influencing IOP, either upwards, for example steroids, or downward, for example beta blockers. Pre-perimeter glaucoma. This concept refers to glaucomatous damage usually manifested by a suspicious optic disc or the presence of retinal nerve fiber layer defects in which no visual field abnormality has developed. The field testing modality for this purpose is usually taken as standard achromatic automated perimetry. Management. Raised IOP is an important risk factor in the development of glaucoma and can be modified with treatment. However, it is difficult to justify the treatment of all individuals with raised IOP because of high prevalence of ocular hypertension. The low conversion rate to glaucoma and Cost and side effect of treatment. In the OHTS study, untreated patients with ocular hypertension had a 9.5% cumulative risk of developing primary open-angle glaucoma after 5 years. Treatment which aimed to reduce IOP by 20% or more and to reach 24 mm of mercury or less reduced this from 9.5 to 4.5%. Validated prediction models using the ocular parameters of a given individual with ocular hypertension allows the 5-year risk of developing glaucoma to be estimated and expressed as a percentage. This helps in deciding the frequency of testing and whether to start treatment. In general, only those at high risk should be treated, although patient preference may be a decisive factor. Age and therefore life expectancy is a key point to consider. Most practitioners would treat every patient with an IOP of 30 mm of mercury or more because they have more than 40% 5-year risk of glaucoma. The decision to treat in patients with varying risk profile is not straightforward and has to be made on an individual basis. OHT increases the risk of retinal vein occlusion, an additional point to consider when deciding whether to start treatment. Treatment options are the same as for primary open-angle glaucoma, although a less aggressive pressure-lowering approach is frequently taken. Careful monitoring is a reasonable alternative in many circumstances. Baseline visual fields, retinal nerve fiber layer disc imaging should be performed.